So as far as high penetrance testing is concerned, you have a 38-year-old Caucasian gentleman with strong prostate cancer family history, 2 brothers, one in his late 40s, the other in his mid-50s, and his father was diagnosed at age 60. Given that strong family history, you suggest a genetic test. The patient has the Myriad test, which demonstrates a BRCA2 mutation. The patient has a consultation with a genetic counselor. So the patient informs his family members, which is a little bit of a problem. And upon hearing about her brother's MyRisk result, his otherwise healthy 52-year-old sister tested positive. She had a breast MRI, was diagnosed with an aggressive cancer, which was successfully treated. This is a downstream implication of the MyRisk test. So upon hearing of his son's mutation, the father gets a MyRisk test and is also positive for the same mutation. He's 10 years out from an external beam radiation for intermediate risk prostate cancer with bony mets. He's failed first and second line ADT. He's just started chemotherapy. And upon hearing about his mutation, his medical oncology rapidly transitions him to olaparib, because MyRisk is now a companion diagnostic for this medicine. He's doing well 6 months out. Now the question, who to screen? When to start, when to stop? 58-year-old, otherwise healthy, adopted Caucasian man with lower urinary tract symptoms. You do a DRE, 50 cc, benign. He's on Flomax. He's never started prostate cancer screening. Do you have that conversation with him? Or you like the family doctor who's overwhelmed, seeing 30 patients in clinic and give him a script for Flomax and walk out the door? So by show of hands, who would offer this guy prostate cancer screening? Wow, good, I love it. Does risk assessment factor into your decision regarding screening? Okay. So he gets a prompt. It returns as below average risk at 0.15, with the lower limit of average being 0.6. In a study of 100 men at UCSD with metastatic prostate cancer, not a single man had a prostate genetic score this low. So you're pretty confident he's at low risk of prostate cancer. Does the average man benefit from screening? The average risk man, does he benefit from prostate cancer screening? Jerry would argue no. I love it. The average risk man. Okay, so Jerry's done a good job of convincing you all. So does the low risk man benefit from screening? Obviously not. What would you do? Well, you have a discussion regarding the risks and benefits of PSA-based prostate cancer screening. And in our risk-averse era, of course he gets a PSA. Returns back at 2.5. PSA density is 0.05. We know his risk of Gleason 7 or greater disease is less than 2%. What do you do now? I followed him up in 7 years with a PSA. Okay, so the next is an anxious 76-year-old guy. We know these guys. He's got AFib, hypertension, remote MI with stents, no family history of prostate cancer. He's been perseverating on his PSAs over the last 20 years. He had a PSA of 4.2 several years ago, for which he underwent a prostate biopsy, which just heightened his anxiety. He's an engineer and has charted his PSAs. And this is the PSA-itis or PSA dynia that Lori Klotz talks about. You see that PSA in 2014 of 4.2. He's taken up too much time in his visits. You feel in your heart that he no longer benefits from screening, but he wants it. You offer him a prompt, he gets it back at 0.35. You're both reassured. You stop the madness. True story. 60-year-old, otherwise healthy Caucasian urologist, knows the literature, just like Jerry. He's decided to forego prostate cancer screening. He gets a prompt. His score is super high at 2.8. And the benefit of prompt is really in the lower end of risk, negative predictive value. Its positive predictive value is pretty low. So at 2.8, his risk is pretty high. If our current screening estimates are that we need to screen about 1,000 men in order to save a life, that drops down to about 173 on high-risk prompt. This result prompts a PSA test, which comes back at 4.8. So this dovetails nicely with this. He has a MRI, PIRADS4 lesion with extracapsular extension. We do a uronav biopsy on him, Gleason 4+3. He has a prostatectomy, locally advanced disease, PSA undetectable. So I would argue this is a guy who did very well. So how about this guy? 64-year-old Hispanic gentleman with urinary retention, chronic renal insufficiency on CIC. This issue of PSA on CIC is a tricky one. So his PSA was 8.4, his repeat 8.2, his DRE was benign feeling, MRI 45 cc with a PIRADS 1. So dealer's choice here, you could use Select MDX, PCA3, you could use well, I don't know if the kallikrein markers work very well in this setting, but even the prompt would work just fine here. So you can see here the Select MDX came back as very low risk, and that speaks to the negative predictive value of this test. You feel comfortable, no biopsy. His PSAs are stable 2 years out. So I like the Select MDX test. Who to repeat biopsy? Well, again, you could use any of those biomarkers, including prompts. But here in this case, I use the confirmed test. 50-year-old Caucasian gentleman who has several family members with prostate cancer. He had a negative MRI biopsy, PSA of 3.5, PIRADS of 3. The adjudicating these MRI lesions is, these PIRADS 3 lesions is also pretty important. The risk of false negative was discussed. The patient opted for a confirmed MDX test. This suggested that he was at higher risk. Repeat biopsy demonstrated 3 of 12 cores of Gleason 3+4 disease. He's doing well after prostatectomy for PT2 N0 R0 disease. He's 2 years out, no incontinence. His erections have suffered somewhat. His PSA is undetectable. Did we help this guy by early detection? I would argue yes. We'll never know. So who to treat? Favorable risk, favorable intermediate risk prostate cancer. So a 58-year-old, otherwise healthy man with no family history of prostate cancer. Biopsy for a PSA rise from baseline of 2.5 to 3.5. This case killed me. Single core of 3+4, less than 5% of the core involved on active surveillance. Now, who has used the no error test? Yeah. There are several times, and this is one of those cases where I was thinking, you know what, this just doesn't add up. You know, this biopsy, the initial core and what I'm seeing here just doesn't add up. I considered it. I'm always reluctant to pull the trigger on it. So who to give adjuvant radiation to? Well, this is an example of a case where I think Decipher works really well. 57-year-old African-American gentleman, status post RALP for Gleason 3+4 disease, for locally advanced disease, and a positive margin. It happens. Rarely, but it's been known to happen. So he's 3 months out. He's recovered his continence. He's had some return of erection. You know, this is an anecdote for sure, but you know, this is what we're grappling with when you're faced with an anxious patient, has some pathology, including a positive margin. You're watching them very closely. It's hard to say, and especially, you know, given his lack of complete recovery in terms of his erections. So no change to continence or his erections. But in terms of the practical application of these tests, I think it's really important to use the appropriate test in the appropriate setting and to really understand the benefits and limitations. So In conclusion, genetic tests are going to play an increasingly important role in the care that we provide to men at risk for and with prostate cancer. A good understanding of their strengths and weaknesses are really critical. And as far as cost is concerned, I think we need to stop the insanity with over-testing and come to our senses regarding who best to let into this arena.